And we're live in 5,
4, 3, 2,
1.
We're ready to go? Good. Well, good morning, everybody. My name is Jens Chapman, and today is October 16, 2024, and welcome to this week's edition of STED, Spine Technology Education, and the D stands for multiple different things. As you know, discussion, discovery, discourse, and I'll add another D word to it, disclosures. I have an agenda. It's not a corporate agenda. Yes, my disclosure list is usually very long. It's basically the agenda of spine as an organ. And how does that tie into today? It's fantastic that we have Dr. George Haddad, the Chief Medical Officer of a new and visionary company called OptiSpan here in person, accompanied by Dr. Seppi Debye. She's a PhD, and it's really cool to have these two colleagues here because I hope to convince them that the spine is a filter of life, a reflection of our wellness, and has a strong and interactive role with the rest of our body and our health. And the cases that our four wonderful fellows selected today are going to serve as a discussion foundation. I'm going to introduce both Dr. Haddad and Dr. Debye in detail later during that lecture part, but this is the discussion part in terms of having four cases, and we'll kind of debate what's going on, and I'll be online also to monitor the chat room and any questions you might have on a technical scale, and I really appreciate all of you from around the world of being part with us. So today's topic is really, again, the continuation of the topic from 2 weeks ago presented by Dr. Matt Kaebelen on length of life, healthy aging, quality life. We learned a new term 2 weeks ago, lifespan, an active life, as opposed to the unhealthy lifespan. And that's a really big deal for all of us, especially in our spine world. And I thought it would be a great idea, and I thank Dr. Mark Kramer, who I invite to come to the stage right now, for the first of our four case discussions, to follow up on the first lead-off case from last time that Dr. Kramer presented, where we did not have a resolution of the case yet. And this is an ongoing thing, but we have an important new development. So I'll let Dr. Kramer, who is from the University of Wisconsin, he's a neurosurgical colleague, take us back 2 weeks ago in the introduction of this case that led to so many ethical discussions, and that very much pertains to the subject of healthy aging. Dr. Kramer.
All right, excellent. So this is, again, the same kind of case that we reviewed 2 weeks ago, but we do have a resolution of the case, and we figured it'd be worth continuing the discussion. So just for review purposes, it's an 85-year-old gentleman. He presented after a fall. It was a mechanical fall from standing. And actually, let me just take a quick, okay, this is the correct presentation. So he had a mechanical fall from standing. He was initially placed in the rigid collar at that time, and he has this kind of fairly complicated past medical history. He has coronary disease, hypertension, hypothyroidism, BPH. He also has myasthenia gravis. He's on chronic steroids for this, and he also had some lumbar stenosis and claudication symptoms. So this is the imaging that he initially presented with. You can see it's a type 2 odontoid fracture. And not significantly displaced. So it seemed like a reasonable candidate for a cervical collar at that time.
If I'll just stop you there for a second, Dr. Kramer. I know we discussed this the last time, but Dr. Haddad was not here and Dr. Debye was not here. So this is go back one more time. This is to the past medical history, if you will. So this is a very common scenario for us now. And I think epidemiologically speaking, Dr. Debye is an epidemiologist. The deaths, unexpected deaths from falls are now the second most common cause of demise in human beings in the US. So ground level falls, we're not talking about some scaffolding. OSHA has done its job, but simple ground level falls cause a demise. Head bleeds, hip fractures, yada, 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 and spine fractures, type 2 odontoid fracture. Routine occurrence nowadays, multiple causes in that. So my question to you, and this was posed to Dr. Kabelin also, is as we're trying to decide what to do, we're trying to prognosticate lifespan of a patient, and we try to extrapolate from their past medical history some form of an either official or not so official risk score. So I'll start with you, the MD. How are we doing with predicting an expected survival time of a patient with the information, the limited information that I'm giving you right here, right now?
You know, I just read Stanford has a death score. Okay, so Stanford, a team at Stanford has created some sort of predictive score. It's mainly for internist family medicine doctors to get people channeled into hospice, right?
Okay.
So I think there are people that have worked on that specific question, like what's the risk of 6-month, 12-month risk of death. So you can do that. You can model this. I think when you add a fall in, that's another calculation. But I don't know. What does your literature say?
Well, we'll go. I'll deflect here for a second. Dr. Dubai, can I put you on the spot? Microphone, please. So you're an epidemiologist, but there's another rivaling entity called life insurance companies, and they have actuarials, right?
Yes.
So they have a financial interest. They're pretty motivated to get their scores right.
Yep.
How do you, from an epidemiologic perspective and with your maybe knowledge of what insurance companies do to predict lifespan, handle this? What can we do on a scientific basis to kind of try to predict life? There's a lot of comorbidities here. I'm not asking you to decipher those. Dr. Haddad is way better than I am in kind of validating and quantifying those. But where are we with a objective epidemiologic prediction of lifespans?
So from my understanding, I have data science and machine learning background too. So that's basically what I'm doing at OptiSpan, working on the machine learning and AI. So from my understanding, from the insurance perspective, they are building big models using population data and using their medical data to come up with scores or risk or probability of someone having the risk of falling. So that's basically they're using a big data set from the population that they have and training these models using different kind of variables that they have based on the insurance, and they're building models based on that.
So, Dr. Haddad, if you see these risk factors here, and you're my hypothetical medicine attending colleague on rounds, what would you suggest we do just from a purely medical perspective? Should we treat this patient aggressively, surgically, or should we try to do the least invasive? Because 85, if I checked my data set, this is a male, we're the weaker gender. We've kind of exceeded our lifespan by about age 82. After age 82, we're in the bonus years. And I think that might be a high calculation. I think dip down again a little bit. So what's your advice here? Just looking at computing these little comorbidities without a coefficient. What's your advice? Minimum?
It would depend on a lot of things, right? I'd need to get to know the patient, the family. This person could still be biologically younger than what these diagnoses kind of suggest, or he could be truly at the end of life, right?
So what I'll add in is that at this point in time, the patient is functional. He's been at home, lives independently with his wife, and still has a variety of hobbies he does around his home.
Yeah, so I think we'd have to decide, is our goal to try to get him back home, or?
Give me your gestalt, give me your thumbs up,
My
thumbs
sense
down.
is probably thumbs down,
Okay.
based on,
Wait, George, I thought we wanted him to live forever.
well, yeah.
Let's get him out of the hospital. What the heck? He needs to see you in clinic ASAP.
Dr. Dubai, give us the
Genetic
numbers.
profiling.
What is the current expected average lifespan of a female in America? What is the expected lifespan of a male in America?
You put me on the spot. So I don't remember on top of my head,
82
but
for
I know
males,
that
85 for males.
female is more than.
That's my knowledge, but correct
Yeah.
me. Okay, so he's in bonus years.
Yes, he's already involved, yes.
Mark, University of Wisconsin, Madison, phenomenal place, the birthplace, people never know that, of Coumadin, of warfarin.
That's right.
Wisconsin Alumni Research Foundation, changed the world, put rat poison in olives, great move. But, so what would you have done with this patient? You know, obviously the case, but just hypothetically, just honestly reflecting back.
You know, I think I would have probably placed him in the collar, and I would have initially tried non-operative management.
Okay, take us forward, because I think that's what we all remember from 2 weeks ago. We don't, minimally displaced type 2 odontoid fracture, neurologically intact, 85 years old, probably, but we'll re-explore the old concept later.
Exactly. So again, this is the initial CT for non-displaced. You know, obviously fracture through the odontoid type 2. And the reason, I guess, surgically these are high risk for non-healing is just the blood supply. The blood supply, this part of the bone is it's kind of like a watershed territory of the bone, and it's because of that ossification across those type 2 odontoid fractures is much different than other types of fractures of the odontoid. So unfortunately, at 3 months, this is his repeat CT on the right. You can see that fracture is still present. There's no bony bridge. There's no healing there. And then on the flexion extension X-rays.
Yes, sorry, go ahead.
You can see that there's actually a fair amount of translation as well, almost 6 millimeters of translation.
Can you run the cursor over that just for our audience, especially that flexion one?
Yep.
So Dr. Scoyen, you're co-author on several papers on geriatric odontoid fractures. Is this a surprise to you?
No, these typically don't heal. So
What's the number you quote a patient after, I hate to say 65, so let's go for 75. What do you quote a patient 70 plus?
I mean, I would probably say in this case, was there C1 ring fracture as well? No, just odontoid. I'd probably say a good 90% chance that it's not going to heal.
All right, so we have a beginning non-union, Dr. Kramer. Here's a board examiner question. When do we speak of a non-union when there's an odontoid fracture?
Yeah, so good question.
I'm a board examiner right now. I'm putting you on the spot.
I can say typically what we do is we wait around like 6 weeks for that initial X-ray, and then 3 months is kind of,
6 months.
6 months.
6 months. Delayed union, definitely 6 months, and it can be a year. So this is the 6 months to 1 year is the proper answer, but 6 months, you can start speaking of a delayed union.
Okay.
So it's a very bradytrophic, meaning slow healing bone, very poorly vascularized, fatty substitution, a lot of sclerosis, a lot of mechanical factors. Yeah, go ahead. So now we have the drum roll part. So non-union, the patient is mentally still, I mean, he's corpus mentis, right? So he's with it.
Patient's actually, despite this instability, is actually doing quite well. He obviously does not like the collar. He's not tolerating the collar very well. So at this point, they opted to treat this surgically, and this is the contract that was chosen at that time.
Wait. So had you prior to, no, show me that construct. Had you prior to coming here seen this construct?
No.
In textbooks?
Textbooks, yes.
In older textbooks? And the
Historical.
perfunctory, yeah, historical textbooks.
Yes.
Dr. Scoyen, you're starting to get gray-haired like me. So had you seen this and ever done this procedure before?
Fortunately, I've never done it before, but I've seen it.
So this is a Brooks-type sublaminar C1, C2 fusion with a structural, in this case, allograft. And this was in my era, growing up, I did this since 1985 plus, and that's how I was taught. That's all we had back then. And so this is a really old thing, but starting at around 1992 or so, this was gone. This is just a supplemental technique now. The detail was important here. We used autologous tricortical iliac crest graft, not some allograft, so biologic healing, and we put these patients into a halo. We did not run around with a collar. So was this patient put in a halo? Was this an autograft?
It was not.
Negative. So now take us forward. So this has an inherent problem. This is not actually mechanically stable. And the second that this wire is cabled down, it kind of subluxes actually C1 on C2. So this is where the halo would come in, which is not done here. The other detail is that the graft has to be properly fashioned so it actually literally wedges into C1, C2. It's a mechanical thing. Dr. Volker Sonntag, formerly from the Barrows Institute, was actually the visionary to describe this important mechanical function of the graft in there. That was not done. This is an onlay kind of a graft. So we have 2 hits against this. So Dr. Kramer, did this work?
Yeah, so he, at this point, had been doing well for about 5 years with this previous construct as shown here. Again, he's back at home with his wife. He's actually pretty functional. And now he's about 5 years older. He's in his 90s at this point. Unfortunately, the timeline is about 1 to 2 months where he's got this progressive decline in arm and leg function. He's no longer able to ambulate independently. He's essentially become bedbound over the last few weeks. And his arm strength and grip strength has become so weak that he can no longer hold on to silverware. He can no longer feed himself independently. And at this point, he represents to us, and you can see from his exam, he's got some brisk reflexes. He's quite diffusely weak on both sides.
Dr. Randy Davis, if I may interject, by the way, from Baltimore, well-known, well-published spine surgeon, he always gives me grief. He says, I was the king of wires, always used them and hated the halo. I agree with the hated the halo part, and I'm sure you're the king of wires, and I'm sure also you're the king of quality bone grafting. So point well taken, but thank you for that comment, Dr. Davis.
So he initially gets this MRI, and then we get a call from the ER. So just because of the hardware that's up there, it's very difficult to see what's going on at the OC junction there. So we ultimately did end up getting a CT, and that's what this shows here.
Dr. Abdul Jabbar, so you were the attending, first of all, let me start. You have an excellent training background. You were at UCSF, you were in New Orleans. You had some of the premier institutions in your background with some really cool spine surgeons. Had you seen these Brooks-type constructs for C1, C2 fixation before, or did you use that in your training anywhere?
No, I had never been trained on this. Again, this is one of the things that we see in textbooks mostly. And you can read about it and in terms of fixation techniques, but I had never been exposed to it either in observation or in practice in my training.
And so without being too specific about the year, this was done 2000 in the late 2010s, right? So I'll just be that vague, but this was done in the more recent history, within the last 7 years, right? So at this point in time, how do you approach a patient where the lifespan has continued to exceed anything? He's now several standard deviations above the routine expected lifespan. So he is now like 7 years past this expiration date, that official lifespan thing. How did you approach this? Because this is a complicated situation. Now, what are the factors that you look at when you see a patient who clearly has myelopathy and can't work anymore?
Yeah, I think, Dr. Kramer can speak more to it, but, this is the value of having a palliative care team. This patient was living a very fulfilling life before he had this decline, which I think is very important. He was very cognitively, acute and able to have a good conversation as to where, we had this discussion. The family was initially, reluctant to consider surgery. But after going through all of the options and, the options for him are, continue to have worse decline, no function of the hands, no mobility, and basically go to hospice care or try to maintain what he has and hope for improvement. They did spend quite a bit of time thinking about the options, and, we can take us forward if you'd like.
So that's a really big deal. Dr. Haddad, so it's hard for me to say Dr. Haddad. I'm tempted to say George, but I'll titulate you with your proper formal title as a formal guest here. Have we arrived somewhere with applying mental acuity, mental fitness scores in routine clinical practice as a simple thing, not a complex 10-page mental status test?
We have cognition scores like a MoCA exam, but I don't think we have very good frailty scores yet, right? I mean, they should be.
Hopkins has a frailty score.
They do.
There's a mini mental score that we thought of applying for one of our odontoid studies.
Okay.
So they have MMS, they have, and we'll talk to Dr. Gold, who's presenting a case next about that. But there are some scores like that. There's a mini mental score, and there's a general frailty score from Hopkins that's been relatively well validated.
Okay, and in what context are they using the frailty score?
That's the question. That's for cancer care, that's for major surgeries. But again, for the spine population, we have kind of started using it more because we realize it's important, but I'm not sure how well it's been actually used like in a fracture, in a geriatric fracture setting.
Yeah. I mean, you can see it's tough to predict, right? I mean, from the initial story, I was thumbs down, but you know, there's a great power to reactive disease care, right? I mean, when I give my talk, we're going to be talking about something a little different, but I mean, you and I know a lot of it is just eyeballs. You know, you look at the patient, you talk to the family. I think scores could be helpful, right? The context I always think about, you know, during a certain stage of heart failure, your life expectancy is just as bad as the worst cancers, right? I think we're biased. We know certain cancers at a certain stage, probably we should go right to hospice care. Yeah, if we had scores where we can get equivalencies, that would be optimal. But again, for this gentleman, it's gonna kind of depend, you know. Again, right now, I mean, what I'm hearing from Dr. Kramer is, you know, that the decision was to suggest hospice, but he doesn't have many other options, right? And we all know if you have a patient and a family that's really wants to like give that last ditch effort, we sometimes end up going in that direction. So I'm curious what you ended up doing.
So let's take it forward, and we'll ask the ethics question to Dr. Debye next then. Dr. Kramer, hypothetical Madison, Wisconsin scenario, what would you have done there? This is a difficult ethics scenario. This is multi-dimensional. Where do you go from here?
You know, I think the involvement of the palliative care team, which was also done here, would have been top on our to-do list. I think it's very provider dependent. I could see some of our providers offering, you know, a more simple operation to decompress things potentially. But others would have said, I'm not going to operate.
Dr. Debye, I warned you, here comes my question, ethics. So you mentioned machine learning, but you also mentioned indirectly that AI scenario. Do you foresee that we'll be subjected to some calculator that basically says, do not operate on this patient, that then tells us what to do? Do you see large healthcare systems basically submitting that? So if I go into Epic and I dial in the variables and the scores that Dr. Haddad and I talked about before, the Stanford score and the Hopkins score, that we will get an algorithm that tells us don't operate, and we'll submit to that?
That's a very good question. I don't think we are there yet, but AI can be used for consultation. But, I was doing some research on the falling scores. There are some validated falling scores that like insurance companies use. So if there is such a model, there should be a model that, considers population health, population data, demographic data, variable data. So all these data will be used for such predictive model.
I can tell you one thing. So I worked in England for a while, and I can assure you that in the UK, this patient would have not received care even in the first place. I know that for a fact, pretty much. Even if this patient had a lot of deep pockets and would go to Harley Street, would have not happened. All right, take us to a conclusion so we can move on.
So we did have an extensive discussion with the patient and family, and we involved the palliative care team. The discussion we had at that time was basically that, if we do nothing, you will continue to deteriorate and get worse. And with his inability to feed himself and his rapid decline, we felt like this would probably end up leading into demise within probably weeks to months. The alternative is that we did not feel there was any way to successfully treat this without doing something bigger in stabilizing this. Doing a simple decompression alone is not going to be, it may be helpful for decompressing his neuroelements, but it would not stabilize things. And doing a 1-2 fusion, which kind of would have been perhaps our initial approach and his initial time of injury would have been challenging because we're, in this case, forced to kind of decompress C1-2 and do a full laminectomy at both those levels. So we ended up opting for a occipital cervical fusion, which is a morbid procedure for anybody, but it was a smooth operation from our standpoint. We were able to get 2 pieces of allograft wedged between the occiput and C1-2, and we're able to get a nice rigid fixation. The vertebral anatomy on the patient's right side was unfavorable for instrumentation, so we did only a unilateral C2 pedicle screw on the patient's left side, and then had good fixation from C3 to C5. So you can see this is the sagittal CT here postoperatively, and then I think. This is also kind of an interesting, this is from a swallow study, because we did counsel the patient that there was concern that he could have some swallowing issues after this operation, and he actually regained, he maintained his swallow function post-operatively and was actually doing quite well. This swallow study also does demonstrate he's got good rigid fixation up there.
How did the patient do in surgery? This is very cool, by the way. I love these studies. Everybody knows I'm fascinated by watching the miracle of swallowing. Next, the miracle of us as human beings being able to urinate. It's one of the more fascinating biophysical phenomena. So it's a miracle. How was the patient in surgery, Dr. Abdul-Jabbar, and did you get any gruff from anesthesia for operating on a 90-year-old, a nonagenarian?
Yeah, unfortunately, we ended up having to do this over the weekend, and there was quite a bit of pushback. I think it's challenging for anesthesia when they come in, and have no context, but obviously these conversations with palliative care happened over the course of a week plus. So, the family, the patient were all very clear that they wanted surgery. So there was some pushback, but, we were able to get the case done, and he was very stable through the case. We had no concerns, fortunately, not a lot of blood loss or anything like that. So he remained stable, and actually did quite well, with a significant improvement in terms of his sensation in his hands and a little bit of strength improvement, even in that early phase, which I think bodes well for him. Obviously, time will tell.
And by the way, thank you, Dr. Davis. He sent us an article, and I'm going to post it with slides into the chat room. Actually, Corey's going to do that kindly, so thank you, Dr. Davis. And this shows, it's an article by Dr. Karim Ahmed, at Johns Hopkins, application of a frailty score in oncologic decision-making. So thank you for that. And it's a cool article, cool pictures in it, so appreciate it. Good so far, and the patient went back to the original state, pretty much not cured, but better, right?
Improved. Still ended up being admitted to a facility. Still, within the first few weeks of recovery. So far, so good.
Yeah, this is a very cool case, and I think, again, surgical excellence, but the real excellence was the diligence and decision-making, which is so hard, and which is a good segue point to Dr. Colin Gold's next case. Thank you, Dr. Kramer.
Can I ask a
Please.
question? So I'm just curious about this patient. What is the history of physical activity? Was he active always?
Yeah, that's a great question, because, Mark, take a microphone here. This is something very confounding for us frequently in spine.
Yeah.
This is why I'm so interested in promoting spine as an organ system. The interaction of neurology and musculoskeletal structure is a big deal. A lot of these patients don't walk or move well anymore, and then it's age, it's dementia, it's deconditioning, it's arthritis. What is frequently overlooked is myelopathy. This patient has a cord compression leading to myelopathy. It's like a chronic form of a cord injury. Subtle, painless, progressive. How do we differentiate myelopathy in an aging patient from other comorbidities like what I mentioned? Mark?
Yeah, so it comes down to the clinical presentation. Patients with myelopathy, they of course, have the classic, very brisk reflexes. The things that you very commonly see, and there was a story for this patient, he had a lot of balance issues as well leading up to his decline. And then kind of bilateral weakness, arms and legs, more so in the arms in this case.
Got it. I mean, my main question is do you consider, so it's a hard decision to do a surgery or not, but do you consider like the past history before, I think it contributes to patients' motivation. Microphone. Yeah, patients' lifestyle in general. So if the patient was active before all these signs, probably the patient will be, more active or willing to be, having healthy lifestyle that helps, improve after surgery.
Definitely a great topic and part of the myelopathy discussion. And let's re-explore that with the next case. Dr. Colin Gold, the University of Iowa. Note that he's not gloating. Past weekend had a majestic victory over the Huskies. Since we're more aligned with Washington State University, a lot of smiles here, but take us into the next case where autonomy of decision-making, predicting lifespans becomes a whole new effort.
Yeah. So let's get into HPI. This particular patient is a mid-60s-year-old woman with a complex past medical history with metastatic breast cancer, ankylosing spondylitis, chronic cancer pain on chronic opioids, who initially presented to the emergency department with what she recalls as spontaneous low back pain and inability to bear weight due to severe pain limitation. She doesn't recollect any particular trauma, but may have had some kind of bending at the waist event where around the time that this happened. She was ambulatory and fully functional prior to this event and could not ambulate after, denied any bowel or bladder dysfunction. She's a retired nurse who lives alone currently. The patient is no longer seeking any ongoing oncologic care for her diffusely metastatic cancer. She's on baclofen, oral dilaudid Valium, Celebrex for cancer-related pain and continuously sees palliative care. Here's her physical exam after transfer to Swedish. Essentially neurologically intact with maybe some pain-limited weakness in the lower extremities. No hyperreflexia, slight L4 hyperalgesia on the left, essentially benign neurologic exam. And here is her initial imaging upon presentation. This is a CT demonstrating a T12, call it a burst or flexion distraction type injury, essentially 3-column fracture with anterior wedging. And you can see better on this sagittal MRI, some posterior ligamentous injury and kind of redemonstrating the acute nature of this burst fracture with posterior element involvement.
So from a surgical perspective, this is, if we see this in isolation, a no-brainer. She has some ankylosis, meaning some spontaneous fusion above. This is a run-of-the-mill AO type. B2.
B2, okay.
Flexion distraction injury, anterior column disrupted, posterior tension band torn. So it's a bending injury, AOB2. So that in isolation would be a no problem situation. Now, and can you show us an image again, just a visual? I don't want to stare at a snowflake, a whiteout screen. Yeah, perfect. So this is a no-brainer, there's no cord injury. The problem is she can't mobilize. She's laying on her side, curled up in bed. Her body morphology does not allow bracing in oncologic patients. We usually don't like to brace very much because it's actually an active and uncomfortable treatment. She has declined further breast cancer care. There's no brain metastases. We obviously staged the patient, right? So brain was clear.
She had diffuse skull metastases and dural thickening, which was maybe indicative of no clear cerebral brain metastases, but definitely diffuse skeletal metastases. And you can kind of see that on the MRI here. She's got this marrow signal change throughout her entire spine.
So there's a diffuse infiltrative disease without large lytic lesions. The tumor burden is there. Breast cancer, I'm speaking to a colleague, a trusted colleague, is very difficult to prosecute, just like prostate cancer is one of the, and marrow disease is one of the big scores in terms of winning oncologic disease battles, at least prolonging quality life years. So it's hard to predict, but she's declined for the care. And here comes something I want to quickly explore with you. Dr. Kablan mentioned that 2 weeks ago, the connectivity. So she's self-isolated. She's removed herself from her family and friends. She lives by herself independently until this fracture happened. How important is connectivity in your decision-making as to life expectation? How important is it for us as human beings to optimize our connectivity, to also optimize our survival chances?
Yeah, I'm going to be talking about what we call the praxis soon, and connect is the fourth pillar in our praxis. It might be the most important pillar, but I think very practically for this patient, what kind of success would she have after a major intervention? And essentially, we can also ask, like, how is she doing with the kinds of oncologic treatments that she's had? So yes, I mean, for tumor boards, or sorry, for transplant boards, for liver transplant, it's a huge part of the calculus of who gets an organ and who doesn't. It's the social network and the support network. So for her, that should be part of our calculus.
So this is a big deal for us, and this was a red flag for me. So
Yeah.
Colin, University of Iowa, phenomenal program, major, you're from the neurosurgery department there, very respected institution. How would you have handled this? This is a difficult conundrum. She has declined cancer care. Mm-hmm. She otherwise, vitality-wise, looks pretty good. She's, however, self-isolated, which is a bit of a cognitive red flag, but she's with it. She knows the day, the time, where she is. She's with it in all standard orientation questions. GCS is, I think, full score, right? So
Yeah.
how do you handle this?
I think, like Mark had said at Wisconsin, is lean on the expertise of our palliative care team. We had an excellent palliative care team at Iowa, mostly led by a former cardiothoracic surgeon, which meant he had really good insight into patients with impending like surgical disease. But also, I thought that something important we did was we had group goals of care meetings where a member of the surgical team would be involved in the palliative care, like face-to-face with the palliative doctor and the patient, because I thought it was very useful to translate surgeon speak, expected outcome, pain expectations post-surgery in just anybody having a surgery, and more so just this individual patient with their particular needs. And then the palliative care people were really good at translating that into the stuff that they deal with every day with advanced age, kind of withdrawal of care decisions, and also cancer end-of-life type care.
Colin, was our palliative care team, George, correct me if I'm wrong, always had a non-medical person part of that panel? They had a social worker, I think, here for many years. Did you have a non-medical person or a paramedical person, should I say, part of that decision-making team to kind of represent the ideals, the values of the public?
Yeah, absolutely. So I guess the most common scenario where we'd have these kind of talks would be ICU-related things with severe trauma, hemorrhage, that sort of thing. And the meetings would often involve surgeon, neurology, if indicated, ICU attending, palliative care attending, so like doctor, the patient's bedside nurse, and the social worker team for the ICU.
Very cool. So what would you have done? Putting the what would you have done question to you now, Iowa.
Yeah. I think, well, I guess we'll get to this a little bit in the palliative care discussion slide I have, but I think it's really patient autonomy and decision-driven. This patient is decisional right now. She's completely lucid, I mean, in pain, but not over drugged at this point where she can't make decisions. So I would kind of give the best guess of what you expect based on the pathology and what recovery would look like, and then just give her an honest answer of that and let her decide what she wants, which I believe is what was done in this scenario as well.
So let's take us forward. How did this further evolve?
So as discussed, we involved palliative care. These are the notes that was kind of jotted down from them in this discussion. They said patient is okay with getting proposed surgery if it will help her pain and help her maintain her independence. However, she also said she is not open to sniffer rehab for any length of time. We completed the POA stuff in the chart, and then confirmed DNR, DNI status, no feeding tube, obviously suspended for surgery time.
So, Dr. Debye and Dr. Haddad, I'm making you two of the three members of the palliative care team. And Dr. Debye, you're the non-physician member, non-medical practitioner member who kind of has the ethics obligation. You have a great statistical knowledge also. What is your advice when you have your panel meeting outside the patient's room? Are you going to say yes to surgery, fix this, or palliative care? And where do you weigh in the patient autonomy?
I think I will wait on the surgery for a while so we can fix the social aspect of this patient, like work, a social worker work with this patient to make sure that this patient has access to, in terms of, mental status and connectivity, prepare some connections and make sure that things are set before going to the surgery. That's my...
But she is in active pain. She's actually curled. This is not being
That's
dramatic.
true.
She cannot get out of bed, so she's curled on her side.
That's true.
She's quite with it. I mean, she can have a good conversation with you, except she kind of loses her coherence when she gets into these logical misdirections. Does that influence your thought?
Maybe it can be done in parallel while, probably it can't, the social worker can work with her.
And Dr. Haddad, you actually did palliative care consults, I think I remember here at Swedish for a while, and always treasured your sage advice. So we had our colleague who is representing the lay faction of the palliative care team vote for, let's wait and see a little bit, but the patient is hurting. What's your advice?
In her case, I think the second bullet point, not being open to skilled nursing facility or rehab for any length of time, I think we'd have a further discussion with her about that. I mean, we kind of want to find out why she's saying that. Is this, is it really a binary decision? Because, no matter whether she has surgery or not, there's going to be there are going to be decisions to be made in that context. I would want to talk with the surgeon and really talk about what is the possible outcome? I mean, can we really manage her pain, surgically? Are there other ways to manage her pain? So I'd want some more information. I think, love to hear what the opinions are in terms of.
Let's ask Dr. Skurian. So you're the attending on call. Here's my microphone. Would you have just said, let's just send her to comfort care? She doesn't want that. She wants to go home.
I mean, honestly, I think these are all issues we deal with all the time. And I think this is totally appropriate. I mean, she can make her own decisions, and she doesn't want to go to rehab. She's not going to go to rehab or
Colin,
sniff.
take us forward. So we decided with the patient, we respected ultimately patient autonomy. We did not make this call easily. We waited for several days because we hoped that something would settle out. Palliative care did a hugely, very, very good and very necessary intervention with her to try to sort out things like what's your quality of life expectation, who's your designated power of attorney, what's your will situation, et cetera, living will. What do we end up doing?
Yeah, I will say, as Dr. Haddad kind of astutely pointed out, the first goal and the second goal are in contradiction here, because this is an expected outcome, I would say, with the big surgery, the pathology, and not being able to physically get out of bed, and being on extensive preoperative narcotics on a scheduled basis. So we ended up doing decompression T11 to L1, T9 to L2, posterior instrumentation infusion, partial corpectomy of T12, and T11, T12 discectomy with an interbody cage placement, local bone graft, and crosslinks. Here's a picture of what it looks like all at the end, sagittal CT scan. So surgery done, couldn't ask for a better result. Radiographically, everything.
How long was the surgery roughly? How much blood loss roughly?
I didn't do the surgery, but my guess would have been like 500 cc's of blood
Under
loss.
500 cc's, and I think 3 hours surgery.
Yeah.
So pretty atraumatic, actually, and uneventful surgery. There was nothing heroic in there. Surgically, this was pretty no sweat kind of a procedure. There was nothing extraneous. Now, take us forward. What happened next?
So this is the post-operative course. The patient is in severe mid to low back pain, preventing ambulation after surgery. Neurologically intact. The pain service is consulted to manage her pain. Ultimately, methadone is started in addition to oral Dilaudid, IV Dilaudid, as well as the Valium and Baclofen, and she was already receiving at home. So she's on a hefty dose of sedating medications. By post-op day 2, the patient decides she wants to go home with hospice care and will not go to acute rehab or SNF, which are the recommendations of physical therapy at this time, given that she can't mobilize. However, she's too somnolent for any kind of discharge to either of these facilities anyway, even if she were willing to go. Things continue, maybe slowly progress over the next 4 days, where pain is a little bit more under control. She's able to mobilize a little bit more. Post-op day 6, patient changes her mind that she wants to go to a SNF and acute rehab now that the pain is a little more manageable prior to home with hospice. However, the opiates are still at a very high dose, and she can't participate in physical therapy. Opiates are decreased so that she can participate in physical therapy. The next day, patient changes her mind back to hospice. Methadone is re-increased, and the patient is ultimately discharged home with hospice care.
From the advantage standpoint, speaking as a responsible surgeon, we had a gain. She actually, after several days, started going to the bathroom independently. No brace, nothing. Much improved from the initial curling in bed. So she has some independence. She has independent bowel bladder control. She actually smiled at us. She was happy, and she had a very wavy, curvy post-operative course in terms of decision-making. So as a medical senior administrator, now if I put that hat on you, you're the big boss. Was this a gain? I mean, in quality of life years achieved, this is, I don't know how long she'll live, but under 3 months probably, but she has regained autonomy. She has had her wish. She's returned home. Is this a gain, or was this a waste of valuable resources?
Yeah, this is a value decision, but I think we would place it under the big umbrella of palliative care. I mean, she received a certain kind of palliative care. Would just transfer directly to hospice with lots of pain meds without surgery have been appropriate? That would have been appropriate too.
We actually told her that. I mean,
Yeah.
the hope would have been that they can provide a merciful end to her, and for the attendant staff there, we should not forget the enormous care burden that patients with unstable spine fractures place upon their care providers. The nurses and nurses' aides do a incredible work, difficult work, to try to keep these patients comfortable and give them quality care. So, but she would have survived maybe a week or 2 in palliative care, I should say comfort care, hopefully less, with enough medications, but this is a very difficult situation. Were you happy as a helping surgeon with what we did? Were you comfortable with it?
Yeah, I think in the long run, her pain will be better controlled. And we saw it over the week of hospital stay, that it was a little bit better every day. It was still, at the time of discharge, not to the level that she wanted. But I think this all happened within the last week. So I think if you were to ask her in 2 weeks, her pain would be better controlled than if we did no surgery 3 weeks out from this fracture and she just went home with hospice with an unstable spine fracture. As Dr. Chapman said, she may have lasted 2-3 weeks before she had some other kind of medical complication from immobility. Yeah, I think this is a palliative surgery ultimately, but the right thing to do based on the decisions that she specified initially. And we ended up meeting the goal of not getting her to a SNF or rehab on the way to home.
So several members in the chat room have said, why not just a kyphoplasty? Great point, like Dr. Gorski. Dr. Davis again, thank you for those comments. Absolutely a consideration. We use kyphoplasty a lot actually in these settings. Here, this is a posterior tension band disruption in the textbook. She has posterior pain. This alone with an anterior column reconstruction was simply pivoted off. That's my best conjecture. Could we have done percutaneous screws? Again, the surgical impact was actually not that significant on her. She bounced back pretty rapidly from that. Took 2 days, yes. So, but yes, we consider that, and yes, it's a valid point, but when a posterior tension band is clearly disrupted, like what it was in her case, and in all regards, this is a 3-column injury in the old parlance. This was just pivoted off. It should have just tilted forward, but good point. Let's go for Dr. Minisali, and he has another angle. Thank you, Dr. Gold. Very nice presentation, good discussion. Dr. Minisali has a question of when to give up on a patient who does not have an end-of-life scenario and complex comorbidities, but simply can't function anymore. So let's take us straight to the point. Dr. Minisali is from the famous Rothman facilities in New Jersey and Philadelphia, and he's happy today because the Eagles just scored a victory, so there's a smile on his face this week.
A win's a win, but yes, thank you very much. So yes, this patient's a 50-year-old female who a lot of the history is 6 months prior to her coming to us at an outside hospital. She came to us with basically symptoms and signs of thoracic myelopathy, lower extremity weakness, back pain, and some urinary incontinence for 6 months. 6 months prior to coming to see us in the clinic, she presented to an outside hospital with nausea, vomiting, chest, and back pain, and she had a significant cardiac workup, which was virtually negative. She did have some troponins at that time and had an echo and I think a CT, all pretty much negative for the cardiac workup. However, during that stay, she had significant left lower extremity weakness that seemed kind of unprovoked. They did a CT head and CTA of the head and neck, and although there was no findings of an acute ischemic or embolic stroke, they did initiate TPA at that time. Within the next day or so, she started having worsening new midline back pain, neck pain, stiffness, and urinary retention. MRI of the entire spine at that time showed concern for leptomeningeal disease versus epidural bleeding hematoma. At that time, an LP was performed. It was bloody, but nothing else was found on that LP. And then eventually she was discharged to home with kind of these same issues without much resolve. And the outpatient neurosurgeons performed multiple CT myelograms. So fast forward 6 months when she came to our clinic, she's not had any surgical intervention. She's had multiple myelograms, really no improvement. And on our exam had significant left lower extremity weakness, hyperreflexia, ataxic gait, and lower extremity, as well as saddle anesthesia. So this is some of the imaging from 6 months prior. We have a MRI on presentation. Her initial MRIs after receiving TPA, which were concerning for epidural hemorrhage. And then the CT myelogram on the right is just a picture, but you can see that there's filling distally. This was a lumbar puncture, more or less, for this myelogram without any proximal filling. And then repeat imaging, once the patient came to us, it'll come up.
Too much information, too much data.
So she was in the hospital for like almost 3 weeks.
Yeah, like exactly.
And then never got better. they never figured out what was going on. And I mean, she had a thoracic arachnoid cyst. She had a lumbar tap, she came to our clinic in a wheelchair and basically could not walk anymore.
So I thought this is a really incredible case, and we'll see an interactive
Yeah.
video, and I apologize to the audience and to our fourth potential case presenter. We'll have to forego that, but I thought this is very important in this context in terms of who gets to decide when we give up on a patient. Because this patient had a simple, Dr. Oskouian just said it, drum roll, no longer necessary, arachnoid cyst. And there were, I don't even know how many MRIs done.
A lot,
10?
and many CT myelograms as well,
And
which
she
is an
was
invasive
progressively
procedure.
paraplegic for a period of
6 months at least.
6 months. She was hospitalized. This is a functional patient. She was in a larger medical facility, no names mentioned here. And again, countless resources, imaging-wise and care-wise, were spent. There were professional disagreements in the facility from what we gathered. And this is, Dr. Oskouian, is this a horrible surgery to do?
No, I mean, honestly, this is what I think is important for everyone is, I'm not sure exactly everything that happened, but I think this is what can happen in modern healthcare and medicine, is that everyone in the world saw this woman while she was in the hospital, and they were all focused on different things,
Silos.
Yeah, there were so many silos. And I think like the stroke neurologist was the person that was initially in charge. So they really went on this. And if you look in her chart, this is the danger of EMR. I mean, everyone copy and paste the initial diagnosis, which is stroke.
Yeah.
So everyone said, oh, this patient has a stroke. It's all over chart. And this woman never had a stroke. She presented with thoracic myelopathy. And I think this is what happens nowadays is someone makes a diagnosis and then it's just sticks on the chart and it goes in every single note. In fact, when I saw her, that was her diagnosis, is follow-up stroke patient in clinic.
I mean, bless whoever had the decision capacity to get a second opinion out of the initial healthcare system and it's come to you, Dr. Oskouian. So this is, and by the way, there's a phenomenal evening discussion. Look at it on SSF TV library. Dr. Nuj Kazemi from the University of Michigan and his colleagues gave a specific Tuesday evening interesting case discussion on cysts, and I think he called it cysts and boogers or something like that, don't quote me on that, of the spinal cord, and webbing, what you should know. Yeah, cysts, webbing, and boogers, what you should know. And he specifically talks about this. Take us through the further stuff so we can go on to honorary lecture.
Yes, we plan to do a T1 through 5 laminectomy, and she underwent a posterior T1 through 5 laminectomy and decompression. These are some of our intraoperative microscopic images. So on the top left, you can see we've already opened the dura. The laminectomy's been performed, and you can see the significant cyst and webbing. Top right is during some decompression, and then bottom left is again decompression of the cystic areas. And then the final bottom right is the dural repair with 4-0 Neuralign in a running locking fashion. I'm orthopedically trained. This is the first time I've seen this type of procedure and assisted with Dr. Oskouian. It was a really great case. And the patient, did well afterwards. You don't expect immediate neurologic changes or recovery. She went home on postoperative day 5 and, made some small improvements over time. But, the longevity of this case will show if she kind of makes improvements over time. But
the key thing is, first of all, this is beautifully done, of course, in your artistic hands. But if you're really honest, this is not a horrendously complex surgery. I mean, you make it look easy. I get that, but right?
No, I mean, it's actually, technically, it's, for neurosurgeons, we do this a lot. But in her case, I think, again, I think you just have to fenestrate and connect. You have to marsupialize the cyst and basically take the wall out and then get it to connect with the subarachnoid space. And she got better. I mean, before discharge, she was actually walking,
Yeah, she's doing better.
which she hadn't done in like 7 months, which is pretty remarkable. Usually it takes them a few months to get better. So,
Perfect.
All right, with this, we'll conclude our case discussions. And again, just to introduce our guest speaker and his visiting helper, it is a great honor to have Dr. George Haddad here. This is our second presentation in sequence with the previous one with Dr. Matt Kabelin with age and age-related problems and how can we expand our meaningful health span of our life, not just lifespan, but health span, a concept discussed by Dr. Kabelin. To Dr. Haddad, he has undergraduate degrees and medical education at New York, Buffalo, and he studied philosophy and ancient Greek and German. Man spricht Deutsch. Sehr gut sogar. And he studied at the famous University of Tübingen in Germany, very near and dear to my heart, another conflict of interest declaration. He also did sub-internships at the famous Charité Hospital in Berlin, and again, near and dear to my heart. He studied further medical history and science at Yale and published papers with multiple different aspects of German and American medical history, a very unique situation. He worked and studied as a resident and then as a attending in the Kazan Medical University in Russia. And since 2001 has been in Seattle, so he's a truly global doctor. And he has done multiple teaching stints, for instance, in Japan and China, I saw. He has been medical director of the Swedish Executive Health Program, so a early version of concierge medicine, something that in the US has become a big deal. And he is now the medical director and chief medical officer for OptiSpan, targeting biological aging in the 21st century medicine for something that can hopefully help all of us, and not just a select few, to expand our meaningful quality life years. With this, and without much further ado, Dr. Haddad, bitte kommen Sie her und bitte sprechen Sie zu uns. Great to have you here.
All right, thank you, Dr. Chapman.
Do you need help?
I just need someone to start the slide. Start the slides. Have to,
Can we switch? Has that be open?
it's opened.
Sorry.
It's okay.
Can you show us our new teaching assistant or teaching coordinator with a camera view in the back?
Here it is.
Okay, there it is. Okay, now we'll do that later. George.
All right, thank you, Dr. Chapman. So the talk I'm going to give today, we've had a great segue into it because we've basically talked about the power of reactive disease care. And that's, you know, in my work at OptiSpan, in my history with Institute for Systems Biology, you know, we do what I would call meta medicine, right? So we're thinking about how we do medicine. So there's reactive disease care, and then what we're working on at OptiSpan, Institute for Systems Biology, we call scientific wellness. Let me go on to the next slide here. Okay, so this is what we call the praxis. Now, why did we use this word praxis? It's just a Greek word that means practice. It's, you know, we're doing this in order to create that sense of, hey, let's talk about how we do medicine, not just assume that, you know, we're going to do only reactive disease care. So the challenge for modern doctors, in addition to reactive disease care, is how to put these four components together, right? I think all of us would now agree that lifestyle factors are a big part of determining our quality of life, our health span, and our lifespan. So you can see for us in the praxis, number one, we focus on the four pillars of lifespan. Number two, we look at what we call the systems of health, and this is where systems biology comes into play. We talk about systems in homeostasis or dyshomeostasis. And when I use these terms, this is how we're interacting with patients. I mean, I use terms like homeostasis. I explain it obviously to patients. There's a point in doing this, right? This is very different. The kind of practice that we're pursuing at OptiSpan is very different from a lot of what we see in primary care, which is a quick visit, quick adjustment of medications. We're trying to do that comprehensive, holistic understanding of the patient. And then number three, we call the third component stay alive. This is reactive disease care. This is basically where the three cases that we went through this morning would live, right? We're trying to keep people alive. This is where surgical interventions, medical interventions live. So you can see in the praxis, we don't ignore reactive disease care, but we consider it a component of these other important elements. And then the fourth component of the praxis, we call OptiSpan. This is Matt Kaeberlein land, right? So geroscience, the biology of aging, really took hold in the mid-90s. That's when I was in medical school or doing my training, and I wasn't reading Nature biology. I wasn't reading the journals that would have first started talking about the potential of geroscience. And this is when Matt Kaeberlein was in his lab at MIT, and this is when they did the shocking studies showing that you can target the biology of aging. You can very consistently prolong the lifespan of organisms, yeast, nematode worms, fruit flies, mice. Matt Kaeberlein also has some studies in dogs. There was a recent marmoset monkey study with rapamycin. So, my goal in trying to do the praxis is how do we include this new understanding of geroscience in medical practice? So we first start with the four pillars, and every single encounter with my patients, we talk about eat, move, sleep, connect. So with eat, we first do a deep dive into what the patient is actually eating with food logging, but we also introduce wearables. I don't know how many of you have worn a glucose monitor, but I promise you it's an enlightening experience, right? This is something that all of the patients in the praxis participate in. This is not for people with diabetes, right? So we're learning how to do what we call N of 1 experiments for personalizing nutrition. So that's how we do eat. And then move, if you were to visit OptiSpan, we have a metabolic laboratory, right? So we do full exercise physiology assessments on our patients. We get their baseline, and then we give them true exercise prescriptions. The sleep pillar, it's only been, I would say, in the last 10 or 15 years that I think doctors especially have taken sleep seriously as a very important component of health. In our clinic, we take it seriously. Everyone gets an Oura ring. And again, we train our patients to do what we call N of 1 sleep experiments. And with an Oura ring, it's very easy to do. For example, all of our patients, we have them experiment and see the effect of alcohol intake on sleep. And I find it to be one of the most powerful tools when talking to patients about sleep, and different kinds of other lifestyle factors that go into sleep. Connect, we already talked about. This is our kind of most vague pillar, but we make a real effort. We even try to quantify it to a certain extent using heart rate variability. We do diurnal cortisol testing on some patients. The goal of the praxis is to really understand the patient deeply when it comes to lifestyle. Then we start talking about what we call the systems of health, and this is where systems biology comes into play. Here, our main biomarkers are blood analytes, and then we also use genetics. We use a SNP chip and produce polygenic risk scores for patients. And ultimately, we're changing the fundamental concept of disease, because when I talk about people's systems, right, we're not talking about disease yet. And I'm going to show a very quick case to show you what I mean, right? So imagine you're my patient, you've come, we've done the deep dive into your pillars. Now we're talking about your systems. And when we talk about systems, they're either in optimal homeostasis or they're perturbed in one direction or another. Stay alive, this is disease management, disease prevention. This is really what I did for most of my career at Swedish. This is what we were talking about with the 3 cases earlier this morning. And then optimize longevity. Everyone who does the praxis, we do biological age testing. I think we're the only clinic in the country that does 3 different biological age clocks. We're doing it to understand what these clocks mean. There's some contradictions, there's some discord in our clocks, but I can tell you this, after having used these clocks in about 60 to 70 patients, there's something there. Like, we see certain kinds of extremes, right? I've had patients walk into my clinic, phenotypically, I have 3 women who are about 65 chronologically, but when I do the biological age testing on them, they consistently are almost 10 years younger. And if you look at the way they've lived, you look at their genomics, there's a pattern there. And then, of course, I have the other extreme. I have a 34-year-old, came to my clinic, he looked older. In terms of his lifestyle factors, he was really not doing well. And when we did biological age testing on him, he was consistently 10 years older, right? So again, for us, this is a different kind of biomarker. My goal at OptiSpan is to figure out, how do we use biological age testing in our clinical practice? So this is an ultra simple case. To give you an example, I use this case with lay people. So this is a guy, it's the simplest case ever, right? 28-year-old, he had just gone to his primary care doctor and was told everything's good. Why was that? I mean, the American Diabetes Association still tells us that in the general population, we're supposed to just check a fasting glucose and a hemoglobin A1C once a year. And you can see for this 28-year-old, he's fine. He's normal, he's optimal, that's what he was told. At OptiSpan, we did a fasting insulin. We also did his polygenic risk scores. He had very high polygenic risk for metabolic disease, for non-alcoholic fatty liver, for insulin resistance, for diabetes. So he had very high genetic risk. And you can see he has hyperinsulinemia. He's someone that in our normal net of reactive disease care, he wouldn't be caught in that net whatsoever. So in our model, we're super aggressive. In his case, we told him he had an early signal for diabetes, and we were aggressive in our management. Okay, so now let me transition to really, I would say, the most fascinating and challenging thing that we're doing at OptiSpan in figuring out the praxis. And it's this transition to artificial intelligence, right? So this is just an image that I created with Dolly. I guess that's kind of me a number of years ago at the P4 Medicine Institute. This is when I first started doing what we would call multi-omics medicine. And this is what it amounted to, right? It amounted to me trying to look at multiple sheets of paper or multiple screens and facing the challenge of trying to make sense of a multi-omics data set, right? So imagine we have all these biomarkers. We have the microbiome, we have imaging, we have functional studies, we have whole genome sequencing. Back then, I did the best that I could in telling a story about the patient or for the patient. But the reality is, there's a limit to what the human brain can do. We know all these systems are ultimately connected, right? I mean, the fundamental operating system of the praxis is systems biology. And back then, I said at some point, artificial intelligence will probably be able to make a network graph. And that's what this image is trying to represent, this network graph that will one day be able to model the complexity of human biology. And then we'd call it a digital twin. And then in silico, we could do hypothetical interventions on your biology, right? So this is a vision that's derived from the world of Lee Hood and systems biology. There are people that are actually working on digital twins. But I think when I first started thinking about these things, I said, well, not in my lifetime, right? I couldn't imagine 6 years ago, I don't think very few of us would have imagined years ago or even a few years ago that we would have artificial intelligence tools that could possibly do this. But the reality is it's happening. And Seppi, who's here with me, actually is part of this team that's trying to figure this out. So ultimately, this is what we think is the future. And this is what I'd love to talk to you further about, love to hear your opinions on this. This is what we are actively trying to do at OptiSpan, right? So the idea of the book is the patient's complete health data, and this means everything. So with every encounter that I have with patients, we record, we use AI transcription tools, we record, we transcribe my engagements, for our first day encounters with patients, that could be 2 or 3 hours of a discussion that we record. And then we're putting everything into our database. We're redacting this database. We're creating basically that knowledge base for every individual patient. And then you can see our goal is to train our own large language model in order to create insights. We're doing this mechanically right now. I don't know how many of you have started playing with these tools. I think officially, the last time I checked, Swedish did not want us to use these tools for certain aspects of medical practice. But in our, at OptiSpan, in our environment, we're doing it. We're being very careful with PHI.
George, what do you guys use? Which platform?
Yeah, so we have a partnership with IBM, and they offer something called AI as a service, right? So what's great about this platform is you can use multiple different foundational models, right? So our ultimate goal is to fine tune what Llama 3.2, right, an open source model. But we play with Claude and with OpenAI ChatGPT 4. We also play with the Strawberry Reasoner version of ChatGPT. And I can tell you, it's shocking, right? So when we put everything in, again, it's a matter of human brain bandwidth versus this tool, right? I mean, you saw my image of the doctor trying to make sense of piles of sheets of paper. You know, we do our best in that way, but the reality is that AI can do a better job of seeing these connections than we can. I've already had multiple patients where the AI has produced what I would call systems insights that I would not have seen. Our feeling is this really is the trend of the future. We also have seen glimpses of what might be true virtual doctors. You know, I would challenge all of you, put in the toughest cases. Actually, I would suggest that someone, when you guys do these cases, I'd suggest that someone in a redacted way in the back, go ahead, put it in to OpenAI, these 3 cases, and ask what OpenAI, what that large language model would do. You could ask ethical questions. Sometimes the guidelines will cause these tools not to respond. But I think that would be a cool skill set for someone here to develop, to actively put these cases in and see what AI tells us. Because one of our big goals at OptiSpan is to create that sandbox, right? So right now, no, we're not live with these tools, but we're gonna play with them because we think this is really what's coming in the next decade or so. And let me just go through, give you a quick sense of what our facility looks like. So this is out in Tukwila at SABI headquarters. We call this a discovery studio, right? So we call it the praxis, right? So the praxis is what we do, but it's also the clinic. This is the large screen. It's interactive. A couple of those screens are actually touch screens. So this is how we present the patient with their data. So you can see part of what we're trying to do is change the whole experience of medicine. It's our phlebotomy station. I don't know if you could see there to the left, at the bottom, I have 3 transducers. Something that we do is point of care ultrasound. Right now, POCUS really is a tool for ER docs and for ICU doctors. You know, I got trained in it and said, hey, how can we use POCUS for wellness? And I don't do this diagnostically, right? I do it the way any of us would do a physical exam and then order diagnostic imaging thereafter. But I can tell you, it's a useful tool because I see patients when I do carotid ultrasounds. I can see inflammation. I can sometimes see plaque. The liver, I think, is the most interesting organ when I do POCUS, right? 1/4 of Americans have some degree of fatty liver, either caused by alcohol or processed food or both. And POCUS is a wonderful tool because most of my career, I would tell people your ALT or AST is slightly elevated. You probably have fatty liver. With POCUS, and I don't know if you can see there, that iPad up to the left, we angle forward where the patient is actually seeing me doing the ultrasound live. I do this every day now, and you see how it motivates different people differently, right? If you show someone their liver, and what I do is I capture a window where you can see the parenchyma of the right kidney right next to the liver, right? And that's basically how you judge whether there's fatty infiltration. Sometimes it's really obvious, and it's part of this experience, right? So that's the other thing that we're trying to figure out at OptiSpan is how do you create a modern 21st century experience for the patients that leads to benefit, that motivates them. When you think about the exam that all of us were taught in med school, right? Like how many times have you actually felt nodules on a liver. I mean, you can't feel fatty liver. I mean, but Dr. Chapman, the times you have felt those nodules, I mean, that patient is usually far out in the world of metastatic disease or cirrhosis, right? My goal here is to give people the earliest signal for certain problems, typically metabolic disease. There's some more images. This is our gym. Our metabolic lab is in the back corner there. And I can talk, I don't think we have too much time, but I can talk more about what we're doing out in Tukwila and why we're there. But
You can keep the weights on. I think that's one of the most overlooked things. I love the weight studio as a final
Sure.
slide, if that's your finale. So thank you, Dr. Haddad. And congratulations. I feel very proud to get to work in Seattle because cutting edge new developments in tech and medicine have always been one of the harbingers of Seattle, and clearly you're merging both of them together. Here's some questions. So we had a couple of cases here, and what I wanted to ask you, first of all, I want to find your support for spine as an organ system. I disclosed that right from the start, and I think that it's an integral part of our health. I'm just a little spinologist here, but it's clearly the connection of brain to body, not just four appendages, and supports the torso as a whole. So all those organ systems revolve around the spine. Okay, enough said. Brain health. We talked about several cases where brain health was a big thing, and for me, the most fascinating thing is the divergence of biologic and chronologic health. And the one thing I look at, and this is Dr. Kramer's first case, is how well do they interact with me, assuming they're not on opiates or other mind-altering drugs, not an uncommon scenario these days. But brain health, how does brain health factor in beyond the connecting that you said or mentioned?
yeah. In what we're doing at OptiSpan, we're just starting. I mean, we don't have the best, like a MoCA is not the best tool for like a 45-year-old otherwise healthy person. I do know that there are some computer-based tools that can predict or kind of score people for early cognitive decline, but I mean, brain health is a huge part of what we're trying to predict, what we're trying to preserve. Ultimately, in our country, I mean, brain health is about metabolic health and lifestyle factors that will either promote poor cognition or preserve it. So that's really where we are there. I mean, I can look at your SNP chip and give you a sense of your risks. We talk a lot about ApoE4, right? We talk in terms of risk for dementia, but and specifically, what do you mean by?
So we have several public health curses at this point. I'm speaking as a practitioner who is about to see 30 patients in the clinic today. I specifically am talking about dementia. You mentioned that already, and dementia variants. And I'm specifically mentioning and thinking of depression and anxiety. Which the latter two highly adversely affect our outcomes. This has been shown increasingly commonly. So depression, anxiety, and mental acuity or sharpness, i.e. non-dementia versus dementia-influenced cognition. So where can we fit those in? How can we easily screen for those without subjecting patients to further onerous scoring sheets and tests?
And almost every patient has metabolic syndrome, right? So they're all pre-diabetic.
You know,
Virtually everyone.
Virtually everyone in kind of a middle life clinic. Yep. A third of my patients in our corporate wellness program carry the diagnosis of depression, anxiety, right? So, yeah. I mean, what our focus, though, by preserving metabolic health, right? I'll tell you the most powerful tool, Dr. Chapman, that we've had, we call it the Whole30 Whole Food Challenge, right? So this has always shocked me, right? So some group came up with this. It's basically an elimination diet, right? So for 30 days, you commit to no processed foods. But in the context of this challenge, bread, rice, pasta is processed food. I've done this many times with patients, and it always shocks me. So I have a writer, right? He's in his mid-50s. His job, he's a writer. This is what he does. He uses his brain. But he, when I saw him, he had prediabetes, he had classic, metabolic disease, he had fatty liver when I did point of care ultrasound on him. I told him, let's do this. Let's do a 1-month challenge, no processed food. 2 weeks in, he contacted me and he told me that he really feels better mentally, like he's reading and writing better. So he's someone, he also has depression and anxiety. So no, I mean, this isn't the only solution, but this is the first thing that we should be doing, right? Is taking out the daily toxins that we're taking in. In the case of this guy, it made a big difference, right? So our focus for brain health and for depression, anxiety, our focus is first the pillars, right? This is why we start with the 4 pillars. And then, of course, we do use medicines as indicated.
Can I add a point? So we also have coaches in the program that they are focused on helping patients individually. Yeah. So they will be working on the connect aspect with the patient directly if there is any need. We will also do referrals, I guess,
Spine coaches, you need spine coaches.
It's a big deal.
Yeah.
And as you know, we were part of that.
Airvale.
Airvale.
Yeah.
And there was a nutrition coach and.
Yeah. No,
I thought that was the most helpful part of it.
Yeah.
Because they would follow up with your labs.
Yeah.
How are you doing?
Yeah.
What's your diet look like? That kind of stuff.
Yeah, and we are also working on developing, virtual coaching platform to be able to scale. So now currently, we have individual coaches that are in touch with patients. Yeah.
Yeah.
This is actually, picking up on what Dr. Osgood just said, metabolic syndrome is real. We see it in spines all the time. The manifestations of chronic inflammatory disease, especially in males, is pervasive, absolutely pervasive. And the breakdown of collagen, the drying up of collagen in women, even fit women, this is actually going to be Dr. Hogshead's case, we'll present it at a future STED talk, is profound. This is you would have been proud of this woman, and her collagen is just basically dried out and breaking to pieces, and we can't do anything about it. So there's a lot to discover still in terms of our optimal nutrition. And I'm not even going to go into people who voluntarily self-harm, like the ongoing drug crisis, and people who voluntarily don't want to live longer, but basically subject themselves to harmful, mind-altering, escapist medications. Let me ask you about the tech angle, though, and that is, in terms of the various monitoring devices, have you thought about using digital phenotyping at this point in time?
Do you mean like a wearable?
No, you have wearables, but there's something way beyond that, and I owe that to Dr. Mark Kramer, who's not here. Digital phenotyping is from the Harvard T. Chan lab, and they basically use standard smartphones as a passive form of data gathering of not just our activities, but our mood and our connectivity, et cetera. Is that something that you've explored?
No, not yet.
I like that. I thought this is a phenomenal next-gen thing, because it really, the Beiwe, B-E-I-W-E tool is an amazing open door opportunity to actually look at our patients' wellness without them having to fill out forms or anything like that. And we can actually gain perturbing or interesting or helpful, however you want to look at it, insights into where we are with these patients, what they do. So aside from calorie counting, and I don't want to diminish that, and fatty livers, which is scary, it is a amazing new technology to us. As you collaborate with IBM, I think they're not involved in this digital phenotyping, but I thought this is way beyond wearable rings and smart watches. Yes, I have my Apple Watch and I look at it every single day.
So what we call that is the dark matter of scientific wellness, right? So one of the challenges, so Lee Hood kind of founded this concept of scientific wellness, you can present today great data to people, right? I mean, essentially that's what we're doing. But do we know what happens when the patient goes home, right? So this is why I call it the dark matter. So I know, Dr. Chapman, I hear what you're saying, that like, we're trying, you know, the more tools we have to uncover that dark matter. So part of what we do when we do the pillars, we try to really understand the belief system of the patient, meaning their self-talk. You know, what do they believe about eating? What do they believe about exercise, right? A lot of people will say things like, oh, I can't lose weight. I'm always this, right? So we are in certain ways trying to uncover that dark matter. But the other thing, Dr. Chapman, I remembered something you came up with 6 years ago. We joked about having a prehab clinic, right?
We don't joke about it, that's
I know,
real.
it's real. You know, and I mean, you came up with the term and we started talking about it. I would welcome it. If you have patients, I'll do a 6-month deep dive, right? I mean, do a kind of prehab on some of these patients with metabolic disease, in high inflammation, and we'll do this. We'll put them on a Whole30 food challenge. I have seen people, I'll bring numbers next time. I'll show you what a 30-day whole food challenge can do to lipid profile, to inflammation.
Let's go.
Right? So, but I love the term prehab, right? We could even collect data because I think we would see better outcomes, hopefully, right? You know, you send someone to me for 6 months, you let the coaches at them, you know, we'll move their numbers. I know I can do that. We can move their inflammatory metabolic numbers.
And you'll put me out of work.
Yes, actually, well, yes.
I got enough work. I love it. We need to come to a close.
Okay.
Thank you
There's
both.
a question.
Oh, sorry, Dr. Gold.
Sorry, quick question. When you see patients in your clinic who are on a wellness check and maybe their biologic age exceeds their numeric age, but they're kind of in a sub-diagnostic of classical disease threshold, would you say it's more often a problem of a knowledge gap? That they don't know that they're doing the wrong things to put themselves in this precarious situation? Or is it they know what the right things to do are and they know they're not doing them, but it's more of an attitude of what's not going to happen to me? And then you have to do the liver ultrasound and show them like, no, this is your liver.
Yeah. Okay, this is the dark matter of scientific wellness, right? Meaning there truly are some people that don't know, right? So I had one patient, I can pretty much tell you why she got diabetes in her early 50s, right? She would have these huge bowls of Honey Nut Cheerios, right? The box has a heart on it, so she thought, oh, this is good for me. We put a CGM on her and she saw what happens, right? I mean, so in her case, it was knowledge, right? She really did not have the right knowledge. No, we have a lot of sophisticated patients that they kind of know the right things to do. They don't know their low-hanging fruit, right? I mean, I've had patients, they come in, they eat well. I had one patient, he was getting up at 3 a.m. every day, going to a gym, right? He had good connection in his life, but he had no idea that like sleeping 3-4 hours a night was going to devastate his metabolic health and his inflammation, right? So this is what we try to do, right? We try to give people the right knowledge, but then motivating people, that's the dark matter, right? How do you can give people perfect scientific advice. How do you get them to put that into their lifestyle, right? So.
Thanks, George.
You need to come to a close. Thank you again.
All right. Thanks, man.